So I'd like to introduce our speaker today, Dr. Amy DiPietro. Dr. DiPietro is a pediatric cardiologist currently in our Norton Children's Heart Institute. She graduated medical school from the University of Toledo in 2005 before completing a MedPeds residency at Penn State. And then she went on to do a fellowship in pediatric cardiology at the Medical College of Georgia and another year-long fellowship in pediatric heart transplantation at Texas Children's Hospital. Dr. DiPietro is currently our pediatric cardiology progressive care unit medical director, and she will be talking today on dyslipidemia. It's not just an adult problem anymore. So I'll turn it over to you.
All right, thank you very much. Okay, so dyslipidemia, it's not just an adult problem anymore. I have no disclosures. And today we're going to talk about why should we be bothered about dyslipidemia in children. We'll review coronary artery disease and the connection with atherosclerosis, and we'll talk about how this process starts in childhood. We'll briefly review how obesity affects this problem and list some related genetic syndromes, and then we'll talk about who should be screened. We'll review the evidence that has been put forward to justify universal screening and talk about when additional screening is needed based on the risk factors. Finally, we'll review how to treat. This will include suggestions on when to refer patients, lifestyle modification, and drug therapy. So let's first start with why. Why should we care about this topic as pediatricians? Most of us went into pediatrics and we have a healthy appreciation and affinity for preventative care. But this really hasn't included things like cholesterol until more recent times. However, as we're going to see, dyslipidemia leads to atherosclerosis, and I'm going to prove to you that this process begins in childhood. So, since we don't talk about atherosclerosis much in pediatrics, I just wanted to remind everybody with this beautiful picture what a serious problem it really is. Cardiovascular disease is the #1 cause of death in the United States. It accounted for 26% of all deaths in 2022. And it's the most common cause of mortality and morbidity in most of the developing countries. So although myocardial infarction, stroke, they usually occur in middle age or late age, it's been recognized for a very long time now that atherogenic processes start in childhood. We know that atherosclerosis causes coronary artery disease and myocardial infarction, but it can also result in things like vascular dementia. And certainly there's a possibility that other chronic healthcare issues are a result of atherosclerosis, and with time, we will see these. So this is not going to be a talk about cholesterol pathways. However, I do want everybody to be a little familiar with the basics in the language. So I just have one slide about this. Different forms of cholesterol exist. Chylomicrons are the least dense and the largest, and their atherogenicity is kind of uncertain. Chylomicrons then undergo a maturation process, and with successive hydrolysis of the triglycerides, the size of the chylomicron will decrease, and they become more dense, forming chylomicron remnants. And these are rapidly removed from the circulation by the liver. The next dense class of lipoproteins is the VLDL particle, which is rich in triglycerides. With lipolytic removal of the triglycerides, the particle size of the VLDL will decrease and the particle density again increases, and the VLDL is converted to a cholesterol ester-rich LDL particle. The LDL particle is the primary transporter of cholesterol to the peripheral tissues, and this is the most dominant form of atherogenic cholesterol. HDL is the smallest of all the cholesterols. It's the densest lipoprotein, and its job is to return excess cholesterol to the liver, where it is converted to bile acids and then eliminated. Therefore, HDL protects us from atherosclerosis development. It's the combination of the LDL and the VLDL that is called the non-HDL cholesterol. And this is more atherogenic than either of the lipoproteins alone. So I'll start by presenting some evidence from two studies that show that atherosclerosis begins in childhood. These are both really good longitudinal studies. The Bogalusa heart study started way back into the 1970s, and the Young Finns study started in about 1980. They look at cardiovascular determinants of health in children, and then they followed their cohorts through adolescence, young adulthood, and even older. They're continuing to get data from these studies to this day. And I'd like to point out the maps only because we have to remember that we still need multi-ethnic studies to mirror all the different populations of kids that we are currently seeing. So there are multiple studies which have been published from the Bogalusa heart study. But let's talk about a couple of the autopsy studies. The design of the study, the one that I want to talk about, the design of the study was to take a 3,000 person cross-sectional survey each year. And then the first report was done in 1986, which at that point, they had done 3 surveys and completed them. The second report was in 1998, at which point they had 7 completed surveys. They concurrently did what they called a community-based autopsy study, where they got parents or the coroner's permission to do autopsies on patients with deaths that were not related to cardiovascular disease. The data obtained from the autopsy findings was compared with the risk factor data that had been obtained as part of the Bogalusa heart study. And then in the study from 1986, they had 88 autopsies. 35 of these were from the Bogalusa heart study. And then in the 1998 study, they had 208 autopsies. 98 of these patients were part of the Bogalusa heart study. So this is figure 1 from 1986. The graph represents young adults or children who died between the ages of 3 and 26. On the x-axis, there are different risk factors, including total cholesterol, triglycerides, LDL, and HDL. They were looking at the percentage of fatty streak involvement and did a Spearman correlation to look for associations. Serum total cholesterol and LDL were very significantly correlated with fatty streaks in the aorta, while VLDL was associated with fatty streaks in coronary arteries. This was from the 1998 study showing the effects of multiple risk factors on the extent of atherosclerosis. Values shown are the percentages of the intimal surface covered with lesions in subjects with 0, 1, 2, 3, or 4 risk factors. And their risk factors included BMI, higher blood pressure, elevated serum triglycerides, elevated serum LDL concentrations that were greater than the 75th percentile of their population in their study group. There were 52 subjects with no risk factors, 20 with 1, 14 with 2, and 7 with 3 or 4. It's easy to see from this that the risk factors, as the risk factors increase, so does the percentage of the intimal surface covered by the fibrous plaques. So another big longitudinal study that is kind of shaping the pediatric lipid management is the cardiovascular risk in the Young Finns study. This was a program launched in Finland in the 1970s and is still ongoing. The multi-center study was designed to study risk factors and precursors of cardiovascular disease. 2 pilot studies were carried out in 78 and 79. Therefore, this cohort has, and thereafter this cohort has been followed many, many times. The participation rate in the follow-up seems to vary anywhere from about 60 to 80%. And in the most recent follow-up, I think there was 57 or so percent of the original cohort. So the results of the study are as follows. The cardiovascular risk profile predicts both coronary artery calcium and carotid intima media thickness. Dyslipidemia in childhood with elevated LDL and triglyceride predict increased carotid intima media thickness independently and synergistically with other cardiovascular disease risk factors. Young adults with a triglyceride level a total triglyceride level greater than 200 had about 5 times the risk of developing coronary cardiovascular disease events 40 years later compared to those who just had a total cholesterol of less than 172. So childhood dyslipidemia predicts development of metabolic syndrome. It predicts development of type 2 diabetes. They found that it predicts development of adult cardiovascular disease at their 25-year follow-up. This is more data from the Young Fin study, and this was just published last year. And I want you to look at the two middle bars. As you can see, if in childhood you had dyslipidemia, and then as an adult it improved and you no longer have high cholesterol, your prevalence of plaque as an adult is higher than an adult who develops high cholesterol in adulthood, really emphasizing the point that atherosclerosis starts in childhood and we should be treating it in childhood. So now we know that there's evidence for early atherosclerosis in children and that dyslipidemia specifically causes it. So let's review some of the evidence for this relationship between dyslipidemia and atherosclerosis. Fatty streaks and fibrous plaques are mentioned in the previous study and are basically early forms of atherosclerosis. The pathobiological determinant of atherosclerosis in the Young study, or PDA for short, evaluated the presence of atherosclerosis at postmortem adolescent. Give me 1 second. So PDA evaluated the presence of atherosclerosis at postmortem in adolescents and young adults between the ages of 15 and 34. These adolescents died of suicide, homicide, or accidental death. This was another autopsy-based study, multi-center, evaluated about 3,000 patients. And the extent of the atherosclerosis in the aorta and the coronary arteries, as demonstrated by the fatty streaks and the fibrous plaques, was then correlated with the presence of abnormal lipid levels, obesity, and hypertension. Non-HDL was shown to be the major correlate of coronary artery atherosclerosis in this age group, with about a 30 milligram per deciliter increase in non-HDL equivalent to 2 vascular years of aging. So childhood levels of total cholesterol, LDL, HDL, and triglyceride are each predictors of coronary artery calcium and carotid intima media thickness. PDA showed that not just lipids, but also risk factors and BMI have been shown to be significant longitudinal predictors of both coronary artery calcium and carotid intima media thickness, which in turn are precursors of advanced atherosclerosis. So now we know dyslipidemia is a significant pediatric health problem. Still not convinced? Let's look at obesity trends and then how this impacts dyslipidemia in pediatrics. Every few years, the CDC publishes information about obesity. The top right corner represents back in the 1980s, where there are several states like Texas, and there are even several states like Texas that don't have data. But overall, the map shows areas with 20% or less obesity. Blue represents areas where there is less than 20% of the population that is obese. The bottom left corner represents the early 2000s. Here, less than 25% of the US was obese. The bottom right corner represents 2010, about 14 years ago, and 20 to 30% of the country was obese at that time. Notice there are no more blue states on this graph at this point. Skip ahead 5 years, and in 2015, we now have 4 states that were greater than 35% are obese. And there's only 6 states with less than 20% obese in their population. Then on the right, the 2022 data shows there are no longer any states with less than 20% prevalence of obesity. Kentucky and Indiana currently have 35 to 40% of the population that is obese. Boys have a slightly higher obesity prevalence when compared to girls, although statistically this really isn't significant. This is data from WIC participants ages 2 to 4 from 2014 to 2020. Young WIC participants have higher obesity rates than the general population of children. The most recent study of young children enrolled in WIC showed that there's still a racial and an ethnic disparity. Greater than 30% of American Indian, Alaskan Natives, and Hispanics were obese, while 20 to about 30% of the whites and blacks were obese, and only about 23% of Asians are obese, which is still a pretty high number. The major increases that we are seeing in obesity are associated with major increases in dyslipidemia. The predominant dyslipidemia pattern that we see in childhood is the combined pattern associated with obesity. You see a moderate to severe elevation in triglycerides and normal to mild increase in LDL and a decrease to HDL. If you're still not convinced about why this is an important topic for us as pediatricians, there's a more traditional answer about why we should be looking for these problems, and that is to identify potentially fatal genetic syndromes. The most important of these is familial hypercholesterolemia. The homozygous version will lead to LDL levels that are off the charts and myocardial infarctions as early as teenagers and some children if left untreated. Oops. Heterozygous familial hypercholesterolemia is much more common. It's about 1 in 500. It has an incidence of about 1 in 500 and will present with LDL levels and a lower range than the homozygous, but it's still typically above 200. And this is basically, both of these are basically a problem with the LDL receptor. There are a few other syndromes here that we all should be aware of, but I think the other one that tends to come up the most is familial hypertriglyceridemia, which is actually pretty rare compared to the other two, and familial combined hyperlipidemia, which is the most common. It's not the combined disorder is not related to one specific gene, and it can be related to obesity, as we discussed. So now that we've covered why, we're going to review who, as in who should we be screening. We're going to go through the specific recommendations at different age ranges. We're going to include the recommendation for universal screening. We're also going to review when to screen outside of the universal screening recommendations. So let's first talk about the rationale for universal screening. I'd like to start by examining the extent of the problem of dyslipidemia. How common is it today to have an abnormal lipid profile as a kid? Well, this is a study from JAMA, and it's looking at the prevalence of dyslipidemia and abnormal blood pressures from 1999 to 2012. Patients were taken from the National Health and Nutrition Evaluation Survey. The top line shows that the total number of patients that they looked at was 1,482. If we think about abnormal cholesterol as any problem including high cholesterol, high non-HDL cholesterol, or low HDL, then at least 20% of all patients from 8 years old to 17 had abnormal lipids. This was slightly higher for girls and slightly higher than average for the kids from about 13 to 17. I also want to point out a couple of the other numbers that are relevant. When looking at dyslipidemia by race, they found that Hispanic children had the highest prevalence at 24.2, getting closer to the 1 in 4 patients. And non-Hispanic Asians are shown to have the lowest numbers at a percentage of 16.6. Again, still high. Finally, I want to point out that the scariest number is at the bottom, which shows that patients who are obese have a prevalence of dyslipidemia at almost 40%. So with obesity, type 2 diabetes, and metabolic syndrome increasing in kids, screening needed to be expanded to include non-HDL, elevated triglycerides, elevated LDL, hyperglycemia, insulin resistance, and hypertension. So then in 2010, the results of the Coronary Artery Risk Detection and Appalachian Communities Project indicated that selective screening would have missed 30 to up to 60% with significant dyslipidemia. And they would have failed to detect genetic dyslipidemias, which require drug therapy. So they showed that universal screening would enable intervention and prevention of future atherosclerotic disease. In response to these trends, the National Heart, Lung, and Blood Institute released a comprehensive set of integrated guidelines for cardiovascular health in children. This was released in December 2011. The guidelines set criteria to identify children at high dyslipidemia risk and recommended screening guidelines and treatment. So let's talk a little bit about these guidelines. The guidelines take us from birth to 21 years old and recommend screening and therapeutic strategies for each of the age groups. This is an overview of what we were asked to do based on the different ages. From birth to 2 years, no screening is recommended. From 3 to 8 years, you screen if there are certain risk factors. This also applies to the 12 to 16-year-old range. And then from 9 to 11 and from 17 to 21, they're asking us to do universal screening. So let's take each one separately. From birth to 2 years old, no lipid screening is recommended. Human plasma cholesterols are lowest during interuterine life and at birth. And then total cholesterol and LDL levels increase rapidly in the first weeks of life and then gradually until they're 2 years old. Screening for dyslipidemia is therefore generally recommended at about 2 years old when the lipid and the lipoproteins become constant up to adolescence. From 3 to 8 years old, selective screening using 2 fasting blood profiles, at least 2 weeks apart, based on a positive history of one of the following. So 1, a parent, grandparent, aunt, uncle, or sibling with coronary artery disease. And coronary artery disease is heart attacks, angina, stroke, coronary artery bypass or grafts, stents, angioplasty, in somebody that is male less than 55 or female less than 65. 2, a parent with a total cholesterol greater than 240 or known dyslipidemia. 3, a patient has diabetes, hypertension, a BMI greater than the 95th percentile for age, smokes or is exposed to secondhand smoke. Or 4, the patient has a moderate or high-risk medical condition associated with cardiovascular disease. These include things like chronic kidney disease, a recipient of a cardiac transplant, Kawasaki disease with current or regressed coronary artery disease, or chronic inflammatory diseases. From 9 to 11 years old is where the universal screening recommendation comes in. Universal screening with a non-fasting lipid profile using non-HDL levels. Then they call for further evaluation with 2 fasting lipid measurements with a positive result of either a non-fasting, non-HDL level greater than 145 and an HDL less than 40, or a fasting lipid profile with an LDL greater than 130, a non-HDL greater than 145, an HDL less than 40, or triglycerides greater than 130. Just for general information, non-HDL is determined by subtracting HDL from total cholesterol and reflects the amount of cholesterol carried in the ApoB containing lipoproteins. And in adults, non-HDL is a better predictor of cardiovascular disease than LDL, as mentioned before, but in children, it's at least as good of a predictor as the LDL. So from 12 years old to 16-year-olds, we're asked to not universally screen because there are normal changes in lipid levels during puberty. At this age, there's a decreased sensitivity and specificity for predicting adult LDL levels and increased false negative results in this group. So this is because there's a 10 to 20% fall in total cholesterol and LDL during adolescence. So instead of doing selective screening using 2 fasting lipid profiles, if you only screen if new knowledge of risk factors occur. So from 17 to 21 years old, again, universal screening is recommended. Ones with non-fasting lipid screen using non-HDL levels. First, further evaluation with 2 fasting lipid measurements is recommended if there's a positive result of the first screen. So in review, if the non-fasting lipid levels are elevated, you obtain a fasting lipid profile and repeat it 2 weeks later. Take the average of the two, and that's what you use. If the LDL is between 130 to 250 or the triglycerides 130 to 500, evaluate for secondary causes and then follow up every 6 months and start diet and lifestyle modifications. If the LDL is greater than 250 or the triglycerides are greater than 500, or the LDL is greater than 160 with risk factors, or the LDL is greater than 130 with diabetes, consider medication and following up every 3 months. So there are many unanswered questions in the guidelines, and the debate is raging in the literature. Gender differences are not really addressed in the guidelines. The timing of puberty affects the lipid levels, and puberty can happen at multiple ages. So women tend to have higher HDL numbers in general, so it's not clear if an HDL of 40 is just as normal in a female as it is a male. I personally question the obtaining of these multiple blood draws. It's not entirely justified in my mind to stick a child 3 times. And the children probably have something to say about that as well. They also have called for indefinite follow-up, even if the lipid levels normalize. This can make a child feel like there's something wrong with them when maybe for years their cholesterol has now been normal. So treatment timing is also in debate, especially when there are no approved drugs for children under 7. Yet if you have homozygous FH, you definitely have justification to start therapy right away. And a big problem that I have is that these guidelines are not consistent with the adult guidelines. So as soon as you graduate into an adult practice, your levels, your goal levels will change. And the cost effectiveness has not been completely fleshed out either. So in review, here are a few practical considerations that I use when deciding who to screen while still trying to stay within the guidelines. I would consider obtaining 1 fasting blood draw instead of 2 or 3, unless you have the ability to draw labs in the office and you think the patients are maybe not reliable enough to get it done at a later time. So another practical thing that another thing that I like is the avoiding of the extra sticks. Consider getting a direct LDL measurement in certain cases. LDL is typically a calculated number in a fasting lipid, a normal lipid profile. And if the triglycerides are high, it can't calculate that number. So if you think the triglycerides are going to be high, go ahead and get the direct LDL measurement on that first stick. In patients with diabetes or patients who are very obese, this is something that you can easily do. So if you're getting confirmatory labs and you're thinking that a patient might need treatment with a statin, it's also nice to get a CK and LFTs at the same time that you're getting baseline values. This is something that you need to do anyway before starting a statin, so you might be saving an extra stick. So that sort of leads us into how should we treat dyslipidemia? Normal and abnormal levels are written into the guidelines. What do you do once you have confirmed elevated cholesterol? Oops. So before considering any sort of lifestyle and diet changes, you definitely want to go over any possible secondary causes. I'm just going to gloss over these, but secondary causes that should be considered include alcoholism, oral contraceptives, prednisone, retinoic acid, hypothyroidism, diabetes, pregnancy, nephrotic syndrome. And again, the guidelines state that if the first lipid profile indicates that the levels are abnormal, then repeat testing in 2 weeks to confirm that profile. If the dyslipidemia persists and secondary causes are ruled out, then start intensive lifestyle management. And at this point, consider referral to a lipid specialist, which we do have in the area. We have 3 of them, and I am one of them. In general, the first line therapy for dyslipidemia in children and adolescents is lifestyle changes, primarily diet modification, daily physical activity, limiting sedentary activities, weight loss is needed. The lifestyle change in the diet therapy must be emphasized with patient education. If the physician is unable to do this or unable to spend the time educating, then enroll the help of our colleagues. Get a nutritionist or a dietitian. Get physical therapy involved. If the family does not change their lifestyle and their dietary habits, the obesity, the dyslipidemia, etc., they have no chance for improvement. And if these fail, then medications have to be considered. So the main target of management is LDL and triglycerides. So let's start with diet modification for LDL. There are several diets in the literature. For reduction of LDL cholesterol, encourage a reduced total fat, saturated fat, and cholesterol diet. They should increase intake of complex carbohydrates while decreasing simple sugars. There should be no decrease in total protein. We have to be careful to maintain calories sufficient for normal growth and development. And it's been proven that diet modification can safely be instituted anytime after 2 years of age. And low-fat diets may be instituted safely and effectively in children as young as 6 months of age under medical supervision. So the actual diet mentioned in the guidelines is the cardiovascular health integrated lifestyle diet, or CHILD for short, and gives specific recommendations for each age group and each type of lipid disorder that you are addressing. So for child 1, it is addressing LDL, your LDL levels. So for the 6 to 12-year-olds, continue to breastfeed until 12 months old. Don't restrict any fat intake. Limit your fruit juice to less than 4 ounces daily. So normal diet. For the 12 to 24-month-old children, you can transition them to reduced fat, unflavored cow's milk, table food with a total fat of 30% of daily calories, limiting saturated fat to 10% of total calories, monounsaturated and polyunsaturated to 20%, and as little trans fat as possible, and less than 300 milligrams of cholesterol daily. For the 2 to 10-year-olds, their primary beverage should be a fat-free unflavored milk and water. Limit or avoid sugar-sweetened beverages. Limit their total fat to 30% of their daily calories, 10% from saturated fat, 20% from monounsaturated and polyunsaturated fat, and encourage as little trans fat as possible and less than 300 milligrams of cholesterol. And then for the 11 to 21, same thing as the previous group, and encourage high dietary fiber as well. So child 2 is specifically targeted for high triglycerides, and start with only 25% of the calories coming from fat. Saturated fat is reduced to 7% of the calories. All trans fats should be avoided. Limit dietary cholesterol to less than 200 milligrams, and limit monounsaturated fat to 10% of total calories. It gives ideas on restricting refined carbohydrates by replacing with simple sugars with complex carbohydrates. Don't use sugar-sweetened beverages. Substitute higher fiber foods. And the actual substituting of the higher fiber foods can result in a 16.6 reduction in triglycerides just with that one substitution. So that's a good one. Increased dietary fish, that will increase your omega-3 fatty acids. But to achieve a 25 to 30% reduction in triglycerides, a daily serving of 4.4 ounces of sardines, 8.5 ounces of herring, or 12 ounces of salmon would be required to get to the amount of omega-3 fatty acids that you would need to see a reduction. So not included in child, but worth mentioning is soy-based protein has been associated with a 7.3 reduction in triglycerides compared to animal-based protein. And a diet of mostly plant-soluble fibers like oats, barley, okra, eggplant, soy, and soy protein and almonds was associated with 7 to 9% lowering of triglycerides below the baseline. So these guidelines are clear, but teaching them can be very difficult because how much is 300 milligrams of cholesterol? How much is 10%, 30% of your total? Like, it's very difficult to follow those. So, enroll the help of your dietitian, enroll the help of your nutritionist. And many times it's hard to figure out exactly what the patients are even eating at home. Many patients will say, well, we eat chicken all the time. Well, is that fried chicken? Is it baked chicken? Is it half of a chicken? So really diving into what they're eating is important. The biggest lessons that I have learned is to ask a patient what they like to eat and try to build upon what they're already eating. I ask for what they ate the day before, and I go over, well, this is what you could have done to that meal to make it a little bit more healthy. I encourage the patient to go to the grocery store with their parents so they can help pick out foods that they will eat because kids can be picky. And I emphasize learning to read and, well, to look at the labels and read them, and start looking for trans fats. That's what I always start with. Look at trans fats. Try to avoid the trans fats first, and moving on from that point. I encourage adding more vegetables to the diet. Some children I find will go for days or weeks without even eating one vegetable. I direct the patients to places online like Food Network or other recipe sites where they can look up low cholesterol recipes. And I talk to both the family and the child because they're in this together and both of them have to change in order for this to work. Because in general, the child has learned from the parent their bad habits. So, and if the child is singled out, it's very isolating to them if they can't eat what the rest of the family is eating. I use my plate as a starting point, and most importantly, I work with a dietitian. I can't emphasize that more, is get them to see a dietitian. So with diet cover, there are specific recommendations for increasing physical activity. Increased physical activity is correlated with a decreased body fat and decreased BMI, higher HDL levels, and lower total cholesterol, lower triglycerides, and lower LDL levels. It also is correlated with decreased insulin resistance and lower blood pressure in childhood and in adolescence. So guidelines from a lipid perspective say no TV if you're less than 2. If you're older than 2, then limit to about 1 to 2 hours. Do not put a TV in the bedroom, and encourage the family to get involved and do an active family activity at least once a week. The 5 to 10-year-old should be exercising 1 hour at least 3 days a week. Their total media time should be limited to 1 to 2 hours a day. Again, no TV in the bedroom. Have the parents support them and encourage their active participation in gym class, and encourage a family activity at least once a week. Same thing for the 11 to 17-year-olds and the 18 to 20-year-olds. Start talking to them about physical activities that can be maintained lifelong and year-long. So I know new recommendations just came out from the AAP, and the screen time's a little bit different. One of the differences, they allow 18 to 24-month-olds to watch about 30 minutes of educational TV. So slightly different, but same idea, get them moving more, make them less sedentary. I found that asking for an hour all at once pretty much never happens. I say, go exercise, and they don't do it. So I start smaller. I encourage children and adolescents to pick an activity that they like to do. I make them come up with it in the room with me. And then I make them pick a time. I make them think about their day and pick a time that they're going to do it. Either starting today, I'm like, okay, you're going to leave here, you're going to go back to school, and when you get home, what are you going to do? And then what are you going to do tomorrow, and when are you going to do it? So, that way they pick something they like to do, and they have to think about it and give me a plan. So by having them select the activity, I feel like I get more of a response. If they can't come up with anything, I talk about taking a walk as a family after dinner. I find that the parents very often are obese themselves, and they have difficulty in encouraging activity in their kids because they are also inactive. So walking after dinner provides a good family activity. A lot of kids will have TVs in their rooms, and they will play hours and hours of video games. So if it's really a problem, I start with having them stand up while they're playing their video game, or switch to VR or one of the more active video games. If they carry a phone, a lot of phones now have pedometers on them, or you could add an app that's a pedometer and get them to reach their 10,000 steps. There's a lot of gyms around town that once you turn 13, you can become a member. And at the end of the visit, I remind the child that the next time they come in, I am going to ask them about what they told me they were going to be doing for their activity. So I make sure I write down what they were doing, and at the next visit, that's one of the first things I ask about is how was your, did you do Just Dance? How many days a week did you do it? And so I very much try to personalize it to that individual. So, well, what happens if the lifestyle modification doesn't work? So when is it time to start medication? First off, if you're at this point, refer to a lipid specialist unless you're really comfortable. If the dyslipidemia persists and the lifestyle modification has been instituted for at least 6 to 12 months, then you may need drug therapy. So pharmacologic therapy of dyslipidemia is recommended in all children aged greater than 10 who fail diet treatment and lifestyle changes after 6 to 12 months. With no risk factors, if the LDL is persistently greater than 190, despite the intervention, start LDL lowering therapy. If the LDL is greater than 160 and you have one risk factor, then start therapy. If the LDL is greater than 130 and you have diabetes, that is also an indication after lifestyle management to start therapy. And triglycerides greater than 500, you actually just start therapy. So high-risk conditions, what are those? Diabetes, end-stage renal disease, chronic kidney disease, heart transplant, Kawasaki's with current aneurysms. Moderate risk conditions are things like HIV, Kawasaki's where the coronary aneurysms have regressed, chronic inflammatory disease, nephrotic syndrome. And the main classes of dyslipidemia therapy are HMG-CoAs reductase inhibitors or statins and selective cholesterol absorption inhibitors. There are also bile acid sequestrants, niacin, fibric acid derivatives, PCSK9 inhibitors, and omega-3 fatty acids. So when children have severe primary lipidemia, defined by an LDL greater than 250 or triglycerides greater than 500, they should be treated with drug therapy and lifestyle modification immediately. You don't wait. So let's talk a little bit about the drugs. Statins are the most commonly used medication to treat dyslipidemia in both the children and adults. Statins competitively inhibit HMG-CoAce reductase. By inhibiting that, the statins block the pathway of cholesterol synthesis in the liver. They inhibit the cholesterol synthesis in the hepatic cells. This decreases the cholesterol pool, and it results in upregulating of the LDL receptors. They can lower LDL by 18 to 55%, and they can decrease triglycerides 7 to 30%, and they increase HDL by like 5 to 15%. Side effects are limited and do not affect growth or pubertal maturation. Statins can cause an elevated ALT 3 times above normal in about 0.66% of the users. This has been reported more often in adolescents treated with simvastatin and atorvastatin. And although rare, there's also an asymptomatic increase in CK, and this can be up to 10-fold. No cases of rhabdomyolysis, though, have been reported in children. Clinically monitor for signs of muscle toxicity. Liver function tests and CK assessment was previously recommended every 4 to 6 months, and some are still doing this, but that's actually not currently in the recommendation. Statins are contraindicated if you have active or chronic liver disease, or if you're pregnant, and females should be counseled about associated risks with pregnancy and directed toward appropriate contraceptive strategies. So statin therapy begins with the lowest dose given once daily in the evening. Because the cholesterol synthesis takes place mostly at night, the statin is usually taken at night to maximize their effect. If target levels are not achieved after 3 months, then the dose is increased slowly. Bile acid sequestrants or cholesterol absorption inhibitors can be added to statins if therapy is not met with statin alone. So these are the statins. Atorvastatin, fluvastatin, lovastatin, and simvastatin are currently approved by the U.S. Food and Drug Administration for children greater than 10. Pravastatin is approved for 8-year-olds. Rosuvastatin is approved for 7-year-olds. So these are listed from top to bottom according to potency. Atorvastatin and rosuvastatin are high potency statins, and they decrease LDL by about 50%. The remaining statins have a low to moderate decrease in LDL, and simvastatin is kind of avoided in pediatrics, somewhat due to a few studies showing more muscle toxicity at the higher levels. So cholesterol absorption inhibitors inhibit the uptake of cholesterol. The only one available is ezetimibe. This blocks the uptake of cholesterol, thereby reducing the incorporation of cholesterol esters into the chylomicron particle. And in layman's term, this decreases cholesterol absorption and decreases cholesterol delivery to the liver. The net result is a reduction in circulating LDL particles. This drug class is approved for children greater than 10 years old. And co-administration of ezetimibe with a statin is very well tolerated, safe, results in higher LDL decreases compared to doubling the dose of the statin. So statin and ezetimibe had been studied together in adolescents aged 10 to 17 years old with FH for as long as 53 weeks, which only 53 weeks, but 53 weeks, and found to be safe. So the FDA has approved 2 PCSK9 inhibitors for pediatric patients with homozygous or heterozygous FH. PCSK9 inhibitors are typically prescribed if you fail 2 other therapies. This is a new class, so there's a lot less long-term safety data, but they can reduce cholesterol levels by 61%. The Hauser RCT study showed that 24 weeks of of Repatha in pediatric patients with heterozygous FH was safe and improved lipid parameters compared to placebo. PCSK9 inhibitors are really expensive, and a month can cost anywhere from $5,000 to $14,000, and they are injectables. So bile acid sequestrants, they bind to bile salts in the GI tract and prevent reuptake. These medications lead to depletion of the bile salts and increased conversion of the cholesterol to bile in the liver. The decreasing cholesterol level in hepatocytes leads to upregulation of the LDL receptors and increased clearance of the LDL from the circulations. Generally not well tolerated. A lot of GI symptoms from this. The lipid lowering effect of the LDL is not as much as statins, and they actually can increase your triglycerides. So not first-line therapy. Triglycerides therapy, if the triglycerides are greater than 500, you start a statin and consider adding fish oil, a fibrate, or niacin along with diet and activity. If the triglycerides are about 200 to 500, then a trial of diet and lifestyle modification and fish oil should be considered. Not really going to go into niacin and fibric acid derivatives. They are currently not FDA approved for pediatrics, and so a lipid specialist should be the one ordering those. Omega-3 fatty acids, these decrease hepatic, so they decrease hepatic fatty acid and triglyceride synthesis, and they enhance fatty acid degradation. They raise your HDL 6 to 17%, and they lower your triglycerides up to 40%. But to achieve this dose, really you need the purified capsules. You really can't eat that much. The typical dose of omega-3 fish oils is about 1 to 4 grams per day. And its side effect is intermittent GI issues. Most commonly, they burp fish. And omega-3 fatty acids are also found in flaxseed, and the highest fish concentrations are in sardines, herring, salmon, and mackerel. So do we really need to do this? Yes, I think we do. I think the answer has really clearly been shown to be yes. Obesity and dyslipidemia are endemic in the United States. They are associated with significant comorbidities and complications. Pediatricians should be aware of the screening, the diagnosis, and management of dyslipidemia, and the management of dyslipidemia will enable prevention of cardiovascular disease in adulthood. Finally, I leave you with one of my favorite quotes from the nutritionist Michael Pollan: "Eat food, not too much, mostly plants." Thank you. So, are there any questions?
All right, thank you, Dr. DiPietro. So questions, do we have a dietitian within the Norton system that we can send families to for education?
So yes, there are several. There is a long wait, however, to get in to see our dietitians. We do not have enough. If there is a cholesterol issue, I know as part of our metabolic clinic, we can get them in sooner than most of the pediatricians can get in. But yeah, we need more.
Okay, so related to that, I guess pulmonary and sorry, I didn't know it was on video. Pulmonary and GI have specific dietitians also, but
Yes.
if the children
And so does endo.
and endo, so if they aren't hooked up with those services yet, can they utilize them?
Yes, you can still refer to the dietitian. It's just those services have a higher priority, so the wait is long.
Okay. Okay, so if they need some education, they should try to go through your metabolic clinic.
For cholesterol issues, we
Okay.
can get them in sooner.
And then another question, lifestyle modification has proven to be very challenging in specific populations of kids, such as those with autism or those prescribed antipsychotics. Short of stopping or changing antipsychotics, are there other practical recommendations?
So we actually have a dietitian in the autism center that specifically works with the kids and works on texture and helps with the autistic children. But yes, it's a problem. And so, you know, when I am doing my own counseling, one of the things I do is like put one spinach leaf on a sandwich they're already eating, you know, start the transition very, very slowly. And you know, get them into the autistic clinic, because I think they've been the most helpful to me as getting the kids to be more open to changes, but start very, very small.
Okay. And who should be starting these cholesterol lowering medications? Is that can the pediatrician start this, or is that a lipid specialist?
So it depends on your comfort level. So if you're comfortable with the medications, absolutely go ahead and start. Be aware, you know, of the monitoring that you need to do. But if you're not comfortable, you know, send them to us and we'll do it. You know, I have a clinic that is all I do is high blood pressure and cholesterol during that clinic.
Okay, and related to that, a lipid specialist is kind of a new pediatric specialist for us, and it transverses many subspecialties. So are there lipid specialists that are cardiologists, endocrinologists, GI docs? I mean, are all those, you know, potential lipid specialists?
Yeah, so it depends on your area. So here, I know endocrine does a lot, especially with triglycerides. And you know, in cardiology, we'll do both triglycerides and LDL. There's really, you don't really treat HDL other than with diet modification and exercise. So it depends on your area. My mentor was actually an endocrinologist, and I have attended several endocrinology talks about lipid management, and other areas have GI as their specialist. So it seems to be just who in that area has decided to pick up the baton and keep going. And so with us, it is endocrine and cardiology.
Okay. And with my patients on Accutane, when they have a fasting triglyceride level greater than 500 related to Accutane, we typically would treat them with fish oil supplements. Is this appropriate? Should I also be considering a referral and other treatment while on Accutane, if not well managed with their lifestyle changes?
Yeah, definitely when it's over 500, you want to do more than just the fish oil. And I didn't put this in the talk, but there's some debate in the literature about fish oil. It will lower your triglycerides 40%, but the long-term data in adults on the morbidity and mortality, it's not there. It doesn't have, it's kind of equivocal as whether or not it's actually changing your cardiovascular risk. So yes, do more.
All right. Thank you so much. Good talk today.